All right, this is a lecture on blood products and medications that we give that are going to affect the body's ability to clot, the body's ability to break down a clot, and the emergent interfacility type products that we'll be giving. A couple of things that I want to go over real quick before we start this lecture. Within the state of Wisconsin, the scope of practice as a paramedic and a critical care paramedic, and this is going to answer a question for you in the slideshow a little bit later. But as a paramedic and a critical care paramedic, you are authorized to transport blood products. Now, there's just a key difference on what a paramedic can do and what a critical care paramedic can do. As a paramedic, blood products must be started at the facility prior to leaving. Critical care paramedics in the state of Wisconsin can initiate blood products in the field. There are many reasons why most interfacility services do not carry blood products. It's usually due to cost and equipment restraints. There's an enormous cost to carrying these, and if they go to waste, that's a huge cost in order for the service to eat and absorb. Also, practicality, as most critical care paramedics are transporting patients with blood products infusing, it's usually from facility to facility, so they're already going to be infusing by the time the critical care paramedic gets there. The flight services are usually the ones who are carrying blood products, and the reason that they are doing that is because they're normally attached to a hospital or hospital system where they can cycle those blood products in and out in order to make sure they don't go to waste. So let's go ahead and get back to the slideshow here. We're going to start with some concepts that we're going to review before we get started. And all right, so as a reminder, the average adult, I should have put adult here, has about 5 liters of blood within the body. Now, when would you see blood product infusions? As I just mentioned, typically on interfacility transports. If you're working as a pre-hospital 911 paramedic and you get a flight service responding to your scene, you might see that flight service initiate blood products in the field. Obviously, this question right here is important for you to know the difference. Why or why not? Well, you're introducing something into somebody's body and you kind of need to know what's going on and why you're doing it. So whenever you're infusing blood products, there's quite a few checks that happen prior to putting that blood product into a patient's body. You're usually talking blood type and RH factor, double checking those. It's usually a 2-person job in order to start that infusion. One of the things that can happen is adverse reactions. Worst case scenario would be an anaphylactic type reaction that's treated just like any other anaphylactic type reaction. And you're going to stop the infusion and treat for the anaphylaxis and signs and symptoms. It is very common for patients to become febrile during a blood product infusion. It's treated with Tylenol typically, and it's not uncommon or dangerous to the patient. There's lots of different reactions that can happen with blood product infusion. If you're interested more in those, I can give you some resources, or eventually take the critical care course, and we talk a lot about that there. But for our sake right now, we're going to talk about what you may see on a typical interfacility transport. Packed red blood cells. So this is for patients who need oxygen carrying capability. So think about those types of patients. You'll see right here, anemia. These are also patients that may have suffered hemorrhage, either internal or external. One of the big things that you need to think about is that each unit is 250 mLs. And so you're worried about volume overload. If there is volume overload, it's treated just like volume overload with an isotonic crystalloid. You're talking about positive pressure, positional support, and possibly nitrates if you need to. but it's usually correctable with those two things, and eventually diuresis long term. Okay, fresh frozen plasma, you'll see once again one of the big things here, about 250 mLs per unit. That is for patients who need help with clotting factors as well. When we talk about cryoprecipitate, these are the assortment of blood clotting factors, but it's not as much volume, so it's a much smaller volume. So patients who may not be able to handle that additional volume would receive a cryoprecipitate infusion instead. All right, platelets you'll see right there. This is used to treat thrombocytopenia. You'll see the definition is a low platelet count. You'll see right here, it's got the type and cross, so the blood type and RH compatibility. All right, so why would we give platelets? Number one, we want clotting to occur and a thrombus is created. We're going to talk about some of these medications that alter the ability of the blood to form the thrombus. That can be therapeutic in certain patients, and we also want to help it in the emergency setting as well. All right, so anticoagulant medications, what do? They prevent the formation of clots and growth of existing clots. What patients would we typically see these in? Well, we'll talk about that as we go through further in this lecture. But remember that platelets are free-floating in your serum, and they're constantly looking for any damaged cells and any bleeding that needs to stop. Okay. All right. So we're going to talk about heparin first. That is an anticoagulant, and I pose this question to you: what patients would you see with heparin? For that, we're going to go over here, and we're going to create another worksheet, and we're going to talk about patients with heparin. Typically, patients with heparin, they are going to have an embolism or clot of some origin that is not causing necrosis actively. Okay, so what patients would you see that with? A pulmonary embolism, typically. So these patients are still oxygenating, still diffusing those gases adequately, but you need to break down that clot. Also, deep vein thrombosis. These are very common. These are typically the patients that you're going to see that are going to be having heparin going in the pre-hospital and interfacility realm. All right, so let's talk about the coagulation system, and we're going to talk about some pathophysiology and some physiology as we go here. All right, so as you'll see right here in the top, you'll see a damaged blood vessel wall, and down here, once that fibrin forms and that blood vessel is repaired, it returns to normal state. Now let's talk about a little bit about how that happens and as a review. So remember, when that blood vessel gets damaged, there's two different pathways that activate and attract those platelets. There's the intrinsic pathway, which is the collagen fibers directly from the blood vessel that say, hey, come over here, clot right here. And then there's the extrinsic pathway, which is any damaged tissue that's around, any damaged cells that further attract those platelets to help clot. Now, before I move on, I want to have you guys think about the 3 A's of platelets, okay? All right. 3 A's are attraction, activation, and accumulation. So in the attraction phase, if we go back to this damaged blood vessel wall. This is where the platelets see that there's damage right here, and all these platelets that are free floating say, okay, we need to go here, we need to go there, we need to go there. All right, now the activation phase, remember when that platelet comes, it actually changes in order for it to be kind of spread out and start taking up space. Accumulation is typically, all that means is that the quantity increases, okay? Most of the drugs that we give with anticoagulation affect the second A here, activation. So it's going to prevent the activation of the platelet in order to be able to spread out and cause a greater plug. And also, some of the ones that we give are going to affect the accumulation and the ability for those platelets to become sticky in the activation phase and further accumulate. Okay, so as we move forward, let's just do a quick review on how clotting factors are released. Remember, prothrombin is converted to thrombin. And what does thrombin do? Thrombin helps transform fibrinogen into fibrin. Okay, now what happens with fibrin? Remember, fibrin is kind of that mesh, right, in that damaged blood vessel wall. And that is actually what creates that clot. So when we affect this, obviously we affect the body's ability to create that clot. All right. This is just a review of what I just went through on the previous slide. But at the end of the day, what we're trying to prevent is that fibrin and that clot formation. Okay, so now we look at this. Heparin works by inactivating thrombin in the clotting process. So it stops the formation of fibrin, and so it stops blood clot forming. So, as we mentioned before, what patients would we see it given for? Those are patients that are typically dealing with clots that we don't want to see any bigger, that are causing potential detriment to the patient. If they're allowed to get bigger, it could get worse. So yes, pulmonary embolism, DVT are the two big ones. All right. So, all right, TXA. This is a big one that we are seeing pre-hospital, interfacility realm, starting to be used very, I shouldn't say commonly, but more mainstream in the EMS world. What does TXA do? Well, it's not an anticoagulant, but what it does is it actually is given for, what's your big indication? Continued hemorrhage. All right, now EMS is very good at stopping bleeding that we can see, compressible bleeding, right? So if you've got a hemorrhage that is on an extremity, we can put a tourniquet on there. We can actually see that bleeding has stopped. We can monitor that, make sure that there's no bleeding that continues. But what about bleeding to the core? Okay, so this is typically non-compressible. So, you've got a gunshot wound to the stomach, to the chest, a high femoral artery. All right, that's when TXA is indicated. Now, what is happening with TXA? There's continued hemorrhage. Within the body. All right, and most protocols will say that's evidenced by tachycardia, hypotension, and one of the big things here is that must be given within 3 hours. Studies have shown that mortality actually increases if TXA is given greater than 3 hours from the injury. What TXA does is it prevents the conversion of plasminogen to plasmin. And remember, plasmin is a factor in fibrinolysis. So what does it do? It prevents clot breakdown. So think about this. Your patient gets shot in the stomach that causes a penetrating wound to the spleen. There's significant bleeding in the abdominal cavity. It's ongoing. Despite your wound packing, there's still signs of hypovolemic and hemorrhagic shock. TXA is indicated. Your body's trying to clot that off. There's all those microclots going on within the body. Your body's also breaking that down. So if we give TXA, it's going to prevent your body from being able to break down those clots and be able to sustain those clots. There's other things that we can do as providers, namely not raise their blood pressure too high in this case, but this is when TXA is indicated. So TXA prevents clot breakdown, and then this is actually how it does it. It prevents the conversion of plasminogen to plasmin. And remember, plasmin plays a factor in clot breakdown. All right, so let's talk about warfarin and Coumadin. This is a very, very common anticoagulant. One of the things that you need to think about when your patients state they are on warfarin or Coumadin, or they fall and they hit their head, one of your first questions should be, are you on blood thinners? Now, why? So the big point right here, life-threatening internal bleeding that we cannot diagnose in the field because it's in a closed compartment. That bleeding can be gradual. It can be very fast. But any patient on blood thinners that falls and hits their head should be transported. That's an important part. So any patient that falls and hits their head on blood thinners should be transported. They should be evaluated in the emergency department. So how does warfarin work? All right. So in the liver, you have all those clotting factors. And remember when we talked about that clotting cascade and there were all those factors, I said, there's no reason to remember those. We'll never use those. Well, vitamin K is essential for the production of those clotting factors. And what does warfarin do? It basically stops vitamin K from being able to participate in the production of those clotting factors. And your body produces less clotting factors that are obviously vitamin K dependent. Now, what would you say if a patient had accidentally overdosed on warfarin, or their INR was way too high? Well, what do they get? They get vitamin K. That's the antidote. But you don't want to be playing this teeter-totter game. As far as warfarin and how that works, it basically stops vitamin K from working within your liver and creating those vitamin K dependent clotting factors. Here are some common anticoagulants. You're going to see heparin often, warfarin often, Eliquis, Lovenox. Those are very common blood thinners. As far as your Xarelto, your Pradaxa, those aren't as common. Warfarin and Coumadin, obviously the most common. There is a very cheap generic form. All right, so let's talk about antiplatelet medications. And what do antiplatelet medications do? They basically prevent the platelets from creating a larger thrombus that is already there, or creating a thrombus altogether. The two that we're going to talk about within paramedic are aspirin and Plavix. Okay, I'm going to show a video here.
Hi, in this video, I'm going to talk about hemostasis. In particular, I'm going to talk about the formation of clots, thrombi, and antiplatelet drugs. Now, first of all, I want to make a couple of definitions. The first one is a clot. Now, a clot is good. A clot stops bleeding. For instance, when you injure yourself, you clot and stop bleeding. A thrombus, on the other hand, is bad. It's also a clot, but it happens within a blood vessel, so it actually blocks the vessels. So let's look at how this happens. I'll draw out a blood vessel here. And in this blood vessel, of course, we'll have some red blood cells. Now, this is a bit of damage to the endothelium. The endothelial cells are the cells that make up the blood vessel walls. So if you get some damage to those, for instance, a break within the vessel wall, then you'll get a bit of collagen exposed here. Collagen is a protein which is integral to the structure of vessel walls. Now, when you have some collagen exposed like this, you get platelets sticking to it. And these are little platelets, they're just floating around in the blood. And they start to stick to it like this. Now, when that happens, the platelets get activated and they release a chemical out into the bloodstream, which calls on more platelets. This chemical is called thromboxane A2. You may have heard of this before in the arachidonic acid pathway. If you haven't, have a look at the video on arachidonic acid and icosanoids on Handwritten Tutorials. Now, this calls more platelets onto the scene. Then, on top of the platelets, we get a bunch of proteins called fibrin. And they're basically big fibrous strands that help make the blood clot, and they stick the platelets together. Then this fibrin will trap a couple of red blood cells in it. And then on top of that, you'll get even more fibrin deposited. And then this process kind of repeats, and this is what causes a clot or a thrombus. Now, this whole process can be avoided if you stop the thromboxane production by platelets. And this is done with a COX inhibitor or a cyclooxygenase inhibitor. Again, have a look at the arachidonic acid and icosanoids tutorial on handwrittentutorials.com for more information. An example of a COX inhibitor is aspirin, and that blocks the thromboxane A2 production. And this means that the platelets won't stick together and the clot won't be formed. In this way, you can actually stop thrombi forming, but a side effect is that you can also get excessive bleeding. And that's an overview of clots, thrombi, and antiplatelets. We'll have a look at how the production of fibrin is controlled in the next tutorial.
Okay, so talking about aspirin. The aspirin that, I'm sorry, let me get back here. I'm going the wrong way. So aspirin, how does aspirin work? Aspirin specifically is a COX inhibitor, and I'm not going to require you to remember COX-1 versus COX-2. Aspirin does affect both, but it seems to be more selectively dependent for COX-1. So what does aspirin do? It prevents platelet adhesion. Okay, and so as you can see, if we go back to this video, and I'm going to pull up that thrombus, let's say this is a coronary artery right here. Well, this thrombus and this clot keep getting bigger and bigger and bigger, and as the blood flow gets more and more and more restricted, we get more necrotic tissue distal to that. And so myocytes die, and you get cardiac muscle damage for the remainder of that patient's life. So it is in that patient's best interest, in order to keep this thrombus as small as possible and keep the blood flow, and whatever blood flow is continuing past that, keeping that intact. That's why we give aspirin. Plavix. Plavix works in a little bit different of a way, but one of the things that you'll see with Plavix, it's typically given in MI patients. And what that does is it reduces the platelet effectiveness. This is not a medication that's typically given pre-hospital, but it works in pretty much not the same mechanism, but for the same reason. It prevents the platelets from being able to accumulate and create a bigger thrombus. All right, now fibrinolytics. These are absolutely medications that you will be transporting in the interfacility realm. Fibrinolytics, you'll see right here. What do they do? They dissolve blood clots. They can cause life-threatening hemorrhage. So before these are given, there's a whole checklist that the hospital will go through, and it's basically to rule out any presence of bleed or bleeding disorders. These patients typically will be your CVA patients and sometimes MIs. If the patient is not a candidate for angioplasty, but they are a candidate for fibrinolytics, your MI patient might receive a fibrinolytic. TPA is one of the most common nomenclatures you will hear, but as far as your fibrinolytics and the actual names of them, you'll see them right there. You will never be starting these pre-hospital. This is always going to be on an interfacility transport, and if you've never seen one of these work, it's pretty cool, because a patient can have significant deficit, especially a CVA patient, and during transport, you'll see resolution of a lot of those deficits as that clot is broken up and perfusion is restored to the portions of the brain. Now, how do they work? They activate plasminogen. Remember, plasminogen releases plasmin, and that will actually help dissolve the clot, and you'll have fibrinolysis and the breakdown of the clots. That's how TPA works. Now, what medication do we give that acts in reverse of that? TXA, remember. All right, so if you have any questions, please make sure you submit them through the assignment, and we'll discuss them at the next class on the second